Welcome everyone to tonight's webinar, Managing Hepatitis C in General Practice. My name is Serena, your RCGP representative for this evening. We are joined tonight by presenters, Dr. Tao Lam, Dr. David Baker. Before we get started, I would like to make acknowledgement of country. We recognize the traditional custodian of the land and sea on which we live and work, and we pay our respects to elders past, present, and emerging. I would also like to acknowledge any Aboriginal and Torres Strait Islander colleagues that have joined us online this evening. I'd like to introduce you to our presenter for this evening. David is a clinical advisor and has extensive experience presenting at ESHM training and has been involved in the development of many of the HCV course materials. Tao is a clinical advisor and has extensive experience presenting at ESHM training and has been involved in the development of most of the HCV course materials. I'll now hand it over to David, who will go over the learning objectives.
Big thank you to everyone who's joined us tonight, and it's great that you're showing your commitment to treating hepatitis C by spending the time with us tonight. What we'd like to do over the next few minutes is to talk about how to identify priority populations for hepatitis C testing, also to demonstrate an understanding of hepatitis C testing options, to describe hepatitis C treatment and how to prescribe, and also to identify which patients require specialised care and how to refer them. Thanks. Next.
I might get started in this section where we'll be looking at the essential steps in treating hepatitis C. So, next slide, please. So why should we treat hepatitis C? Majority of patients who are infected with acute hepatitis C would go on to developing chronic infection, with about 10 to 20% who would then go on to developing cirrhosis over about a 30-year period. However, there are a few factors that may increase the rate of progression to cirrhosis, and they include co-infection with hepatitis B, HIV, excessive sustained alcohol use, metabolic risk factors such as obesity and diabetes. Those with cirrhosis may then develop decompensation, which is when they show overt signs of liver failure or synthetic dysfunction that result in an increased mortality with 5-year survival rate of about 50%. And when you compare this to compensated cirrhosis with a survival rate of about 80%, there's also an increased risk in liver cancer. Next slide, please. So what are the essential steps in treating hepatitis C? First, identify people tested for testing based on risk factors, but please provide a test for anyone who requests a test, because due to stigma and discrimination, they may not want to reveal their risk factor. Number 2, test and diagnose those who have a positive result and then engage them in care. In terms of pre-treatment assessments, get some baseline blood tests such as full blood count, looking especially at the platelet count, biochemistry, check for other serology to determine comorbidity and to assess the need for vaccination, and very importantly, to assess for cirrhosis prior to treatment. For those with cirrhosis, then refer them on for further assessment. For those with severe renal impairment, co-infection, or those with prior DAA experience, you may refer them on. Step 4 is select the regimen. Check the drug-drug interaction. Step 5 is monitor on treatment if indicated, but for a majority of patients, there's minimal on-treatment monitoring. Check for cure at week 4 or week 12 post-treatment, and then follow up as required, especially those with cirrhosis or those with persistent abnormal liver tests. Next slide. So here is the hepatitis C decision-making tool that can help you. It's a resource that provides a really concise and comprehensive overview of the diagnosis, treatment, and follow-up of hepatitis C. You can use the QR code to access the tool. Next slide, please. So what do you do? Step 1, when to test. Offer a test for people with clinical indicators. So for those with unexplained abnormal liver tests, so for a male with an ALT of 30 or above, a female of 19 or above, anyone with unexplained jaundice, those with hepatitis B or HIV infection, those on chronic hemodialysis. Secondly, if a person has risk factors for hepatitis C, then check their status. So those with a current or past history of injecting drug use, sharing of snorting equipment, those who were born in high prevalence region, that includes Africa, especially the Middle East, in particular Egypt, the Mediterranean, Eastern Europe and South Asia. Those who've had blood transfusion of blood product before 1990 in Australia, those who've had unsterile tattooing and body piercing, unsterile medical or dental procedures or blood transfusion and blood product in high prevalence country. People who have spent any time in prison, those with a needle stick injury, and a mother with chronic hepatitis C. Those with increased risk of sexual transmission of hepatitis C, such as men who have sex with men, in particular those who are HIV positive. Other clinical factors include anyone who wants to test, previously mentioned, anyone initiating HIV PrEP. Also consider testing in partners of people with known hepatitis C, planning travel, starting a family, in a new job for ONHS purposes, those with a new or recent change in sexual partner. About 15% of people living with chronic hepatitis C really have no identifiable risk factors, and many risk factors are highly stigmatized, so people may be reluctant to disclose, and so you should offer the test to anyone who requests the hepatitis C screening test. So next slide, let's start with the case.
So we're going to look at a case that represents quite a common scenario. So Isabella is a 32-year-old married office manager, and she's new to your practice after moving to the area. And along with a lot of other people, she is presenting with extreme fatigue. So the past history, she has a history of well-controlled asthma on inhaled steroids and Ventolin. She has 3 or 4 drinks on Friday and Saturday night, but then she discloses that she had briefly injected drugs in her early 20s, and she hasn't disclosed this to her husband and family. Isabella was born in Italy and then moved to Australia when she was quite young. And you do an examination, there's no signs of cirrhosis, you can't feel her liver, but you do notice that she has 2 small tattoos on her upper arm, which she tells you she obtained in Bali in a small tattoo parlor. Next slide. So we're going to have a quick quiz now, and based on that history, what are some of the things that make us think that Isabella should have a hepatitis C test? So we've got several options there. Several answers could be correct. So we'll just wait another 20 seconds or so. So these are the options: brief period of injecting drug use, tiredness, drinking alcohol, tattoos, or being born in Italy. So I think that's probably long enough. So if we can see the results. So we can all go home now because you've got 98% period of injecting drug use. I think that's correct. We're just going to refer now to the Ashton tool. Tiredness is a symptom of Hep C. Alcohol, again, is a cofactor, but it's not a cause of hepatitis C. Overseas tattoo, that is definitely a risk factor. And interestingly, being born in Italy is also considered a risk factor. So being born in a Mediterranean country has been associated with increased risk of hepatitis C acquisition. But my oldest patient with hepatitis C was born in Eastern Europe, and she died at 90 from heart disease, but she had got hepatitis C from probably from a vaccination after the war. So certainly certain countries in Europe had a higher rate of hepatitis C. So we might just close that quiz now. So if we refer to our tool, Isabella had 3 risk factors: history of addicting drug use, which of course is very important, and overseas tattoos from a potentially non-sterile tattoo parlor, and birth in Italy. So 3 reasons to progress to a hepatitis C test. I mean, fatigue is also a symptom potentially of hepatitis C and is a reason also to prompt a test. Alcohol in itself is not a risk factor for hepatitis C. So we might move on to the next slide. So what the best thing in this situation with, we would probably order some other tests to do with tiredness, but we should definitely order a hepatitis C serology and also ask the lab to do a hepatitis C RNA if the hepatitis C antibody is positive. But also, it would be sensible to order other blood-borne virus tests, including HIV and hepatitis B. Next slide. So Isabella's blood test results come back and she's got a positive antibody test. So next slide, thanks. So positive hepatitis C antibody test. Now, what does this mean at this point? It could be consistent with all that apply. You can select any of the above. Current hepatitis C infection, no prior exposure to hepatitis C, or past hepatitis C infection is resolved. So we'll just give you another 10 seconds on this one. So she has a positive antibody test. Okay, I think we can see the responses now, thanks. Yeah, fantastic, yeah, so that's right. Antibody test, she could have a current infection or a past infection that's resolved. So, you've done a great job on that one. So we'll just move on to the next slide, thanks. So positive antibody test means that you have been infected with hepatitis C at some point, but it doesn't tell us if you've got a current infection or not. And for that purpose, we need the RNA test. It's sometimes used to be called the PCR test, and that's a direct test of the presence of hepatitis C. So to say that she has a current infection, we need to have both of these positive RNA. Next slide, thanks. And if we've asked the lab to do a reflex test, they might hopefully have done the RNA test without us having to take off any more blood. So having an antibody and RNA means current infection. Positive antibody, negative RNA means previous infection, but no current infection. And negative antibody means never been exposed to hepatitis C. It's very important that people who previously had hepatitis C treated don't endlessly have antibody tests repeated, because as probably most people know, the antibody tests will generally stay positive for life. So we really need to follow up people with the RNA test. Next slide, please. So this would be probably quite shocking news always shocking news to most people. And Isabella may have been worried about this for some time, that she could have hepatitis C, and you've now confirmed that. So this will be perhaps very distressing for her. So just continue with the slide, thanks. So there's a lot of general advice that we need to give someone for new diagnosis. I think it's very important to also review what their understanding of hepatitis C is, and to think about how stigmatizing this diagnosis is for many people. And certainly at that point, offer counselling and also this very good peer support organisations that are available 7 days a week to provide phone support. In terms of general measures, alcohol is a major cofactor for the progression of hepatitis C, so that's very important to discuss. Also to review her health in general in terms of healthy eating, exercise. In our general checks, we probably already checked for diabetes and lipids when we first met her. So medical issues, it's very dependent on the individual. It's vitally important to address ongoing injecting drug use, if that's not a problem for Isabella, but for many people that is an issue, and it's very important to support people if they need to get into a treatment program, especially if they're injecting drugs like heroin, to offer opioid substitution therapy, also to avoid hepatotoxic medications. As part of investigations, we will have checked hepatitis A and B serology and or HIV serology. So all people need to be vaccinated for hepatitis A and B. And this, for Isabella, it's quite important to discuss the huge advantage in having treatment of hepatitis C prior to conceiving. And of course, every person living with hepatitis C should be offered treatment as soon as possible. Next slide, please. So, pre-treatment assessment, we mentioned having serology checked, and very important, full blood count, liver function, and EUC, and a pregnancy test. So we've done these tests, and we're just going to review the results. Next slide, please. So we've got Isabella's results, and I think the first thing we do would be look at the full blood count, and something that's quite reassuring. Her platelet count is normal, and that's one of the first things I'd always look at. And that's reassuring that she doesn't have, she's less likely to have advanced liver disease. Also, she has normal renal function, which is important for treatment. Liver function, she has raised liver enzymes, which would be typical of chronic hepatitis C infection. Hepatitis B serology, she's immune via vaccination. She might have had a vaccination via the school program. Fortunately, HIV negative, and immunity to hepatitis A. Next slide. Oh, what else should we consider? I think the answer then was a pregnancy test, which we've done. So now, part of the pre-treatment assessment, I'm going to hand over to Tao now because she is an absolute specialist in this area.
Sure. Okay. So it's really important for us to assess the liver fibrosis before starting hepatitis C treatment, because the cirrhosis status can help us to select the most appropriate hep C treatment regimen, and also the duration of treatment. Inform when specialist referral is required, and establish a requirement for long-term follow-up after cure, including surveillance for liver cancer and varices. And cirrhosis status is actually currently required for the PBS approval. Next slide, please. So this is a slide just to remind us to go back to basics in how to assess liver fibrosis. So take a good history, perform an examination, and order appropriate tests to assess the likelihood of cirrhosis. So really the history should document risk factors for the progression of the liver disease, such as the length of infection, the alcohol use, co-infection with HIV or hepatitis B, the presence of metabolic risk factors such as diabetes, obesity, or fatty liver. Examine for signs of cirrhosis and order some basic blood tests, liver tests, full blood count. Platelet count is really important. Dropping platelet count in someone who has chronic liver disease is often an indication that their disease might be progressing. Renal function and coagulation profile if you suspect cirrhosis. The next step would be to use some serum biomarkers, the APRI score or the FIT4 score. So if the APRI score is 1 or greater, it's suggested that further investigation is recommended to confirm cirrhosis. And usually we would use a FibroScan, or alternative might be shear wave elastography. If these tests are unavailable, then other imaging such as an ultrasound or CT scan could be used. But being aware that radiological imaging is not very sensitive or specific for cirrhosis, especially early cirrhosis. And generally, liver ultrasound is used for monitoring cirrhosis rather than for the diagnosis. So, and remember, with invasive testing, no single test is accurate. You should use at least a combination of 2 non-invasive tests, if possible. Next slide, please. So the APRI score is a non-invasive serum marker that can be used as the initial assessment of liver fibrosis. In general, it has really good performance characteristics for excluding the presence of cirrhosis. It's calculated using the patient's AST level, the platelet count, as well as the upper limits of normal AST, which we generally take as 40. So the lower the APRI score, that is less than 0.5, the greater the negative predictive value. So that means that you have the ability to rule out cirrhosis with confidence. The higher the value, that is greater than 1.5 or even higher than 2, the greater the positive predictive value. That's the ability to rule in cirrhosis. As with all non-invasive testing, mid-range values are less helpful as they really don't differentiate between the intermediate stages of fibrosis. Be aware that fluctuating AST or platelet count or low platelet count for other reasons, such as ITP, could impact on the reliability of the APRI score. So we recommend that you should use the APRI score in combination with other non-invasive markers of fibrosis if possible. So if someone's APRI score is greater than 1, please use a second assessment tool to exclude cirrhosis. And this could be the FibroScan or shear wave elastography if that's available for you. Next slide, please. So this quiz number 3. So Isabella's APRI score is 0.43. Is she likely to have cirrhosis? Can we see the results? Yeah. The correct answer is actually A. So she doesn't have cirrhosis, and you probably don't need to consider further testing. Next slide. So using the FibroScan, it's a quick, really easy, non-invasive test to assess for cirrhosis. It measures what we call mechanical shear wave velocity, which is proportional to the liver stiffness. So the test is performed using an ultrasound transducer probe that's mounted on the axis of a vibrator. The vibration is transmitted towards the liver tissue. The vibration is followed by a pulse echo, and the velocity is measured, which correlates directly with liver stiffness. So basically, the stiffer the liver is, the greater the degree of fibrosis. That is, the higher the liver stiffness score, the higher the degree of fibrosis. Be aware, though, that FibroScan really doesn't tell you the cause for the fibrosis, that is the etiology of the underlying liver disease, nor does it provide you any other liver pathology information, such as inflammation. But some models, particularly the latest model, can provide you some information about hepatic steatosis. It's very good at ruling out cirrhosis and also identifying normal liver, but very poor at discriminating those with intermediate levels of fibrosis. So it's really important to note that other factors such as severe liver inflammation, steatosis, obesity, ascites, acute alcoholic consumption, a non-fasting state, and elevated central venous pressure can actually increase the liver stiffness result. Hence, when requesting a FibroScan, it's important to try and provide the information, clinical information such as the liver test, the platelet count, the ultrasound result, or any imaging result that you may have. FibroScan does fail in up to 20% of patients, particularly those with obesity, with a waist circumference of greater than 120 centimetres. It's technically very difficult to measure the liver stiffness in those patients, even with the Excel Pro. But despite this limitation, the FibroScan is very useful to estimate advanced fibrosis and cirrhosis. The liver stiffness for Hep C is actually greater than 12.5. There are some subtle differences in the different liver diseases in terms of the threshold for liver for cirrhosis. So it's important when you refer for a FibroScan that you tell us what the etiology of the underlying liver disease is possible. Next slide, please.
I might just at that point, just a quick comment. Access to FibroScan is quite variable around the countryside, and there are a lot of machines around, but because it's actually not a Medicare item, it's often helpful to refer to a local service who has access to FibroScan, and it may be a clinical nurse specialist who you can ring up and they can do a scan for you. But that depends really on your location.
Yeah.
Sorry.
I think look, like with any non-invasive test, you just need to make sure it correlates with all your other clinical information. And if there is discord, just to reassess and to the patient again. Next slide. A very quick note about the use of radiological imaging like ultrasound, CT scan, or MRI is really insensitive for early fibrosis, but it is useful if the studies reveal liver with a nodular outline, an enlarged caudate lobe, an enlarged spleen with dilated portal vein, with reversal of flow in the portal vein away from the liver, or the presence of portal vein collaterals, the presence of ascites or intra-abdominal varices. Be aware that for liver cancer screening, we recommend 6-monthly ultrasound and alpha-fetoprotein. The combination increases sensitivity of liver cancer detection. However, if you only have one test to do, it will be the ultrasound. Next slide, please. So question 4. Should Isabella be treated now? Can we have the results, please? Oh, that's great. Great to see everyone. A majority of people agree that she should be offered treatment. Next slide, please. So everyone with chronic hepatitis C should be offered treatment because the disease burden of hepatitis C can be prevented through treatment. So for the individual, curing hep C will reduce the progression of their liver disease and increase their survival. For those with cirrhosis, there are other benefits actually, so including reducing the risk of decompensation, such as variceal bleeding, liver cancer, and the need for liver transplant. Not all patients with cirrhosis, particularly those with decompensated cirrhosis, may achieve this clinical improvement. Therefore, it can be argued that you really should treat all patients with mild liver disease before they develop cirrhosis. There's also evidence that curing hep C can improve patient-reported outcomes such as quality of life, neurocognitive function, fatigue, and work productivity. So extra manifestations such as cryoglobulinemia, insulin-resistant, and cardiovascular disease have been shown to improve with the cure of hepatitis C. So the 2022 update for the hepatitis C consensus statement expanded the recommendation of indication for hepatitis C treatment to include all those with detectable hepatitis C RNA, regardless of duration of their infection. This means that you can treat people with acute hepatitis C, which is recommended for people with risk factors for hepatitis transmission. So from a population point of view, the more people you cure of Hep C, the lower the transmission rate, and we can work towards eliminating Hep C. Next slide, please. The treatment's becoming much more easy, safe, and effective, and this is because the oral directly acting antivirals, or DAAs, have the following benefits when you compare them to the older interferon-based therapy. They're easier to administer, being in oral form. They're much better tolerated with fewer significant side effects. Shorter duration of treatment, 2 to 3 months for majority of patients. There's no minimal monitoring while on treatment for majority of patients. There's high rates of cure. So any non-cirrhotic could almost be guaranteed a cure rate of greater than 95%. And even those with compensated cirrhosis, greater than 90%. So curing Hep C had the benefit of improving people's quality of life, increase their survival. So we really should offer hepatitis C treatment to everyone. And I think that with increasing numbers of candidates suitable for treatment, it means that GPs really can play a greater role in curing hepatitis C. Next slide, please.
So we might just go back to Isabella now, and thanks, Tao, for getting us to this point. So we've confirmed that Isabella has hepatitis C with early liver disease, and it's reassuring that I think assessing liver fibrosis is like a jigsaw. You're putting the pieces together, and as Tao mentioned, you want the history examination, investigations, and imaging all to line up, which I think do with Isabella, and demonstrate that she has early liver disease. And so really, effectively, there's two combinations available for her, and they're both very effective. One is 3 pills once a day for 8 weeks with food, or 1 pill a day for 12 weeks with or without food. And really, I think you can, speaking with the patient, you could ask them what their preference would be, an 8-week course or 12-week course, outlining the differences. And of course, from a prescriber point of view, they're really very similar, and they'll both be very suitable for Isabella. So next slide, please. So with genotype-specific treatments, these aren't really, for someone like Isabella, we can just use the 2 common medications. Next slide. If you want more information, there's a very good online reference, Australian Recommendations for the Management of Hepatitis C. And this is widely endorsed around the countryside. And that, if you want some more detailed information, this is sort of the go-to resource. And if you're going to be involved in hepatitis C, I recommend having a look at this guideline. It's very helpful. But actually, most of what you need to know about hepatitis C is summarized in the 2-page ASHRM guide. And that's actually it's evolved over quite a few years, and it's a very good summary of what you need to know. Next slide. So now that Isabella has decided she would like treatment and you're discussing treatment options, it's important to run through possible side effects. So in the question, there's a question about common side effects from the 2 main hepatitis C treatment options. So none, headache, nausea, fatigue, depression, anxiety, or neutropenia. So if people could just choose as a single choice this time. So you might look at the answers now. So none would be very optimistic, but so really they're usually pretty mild, things like headache, nausea, and fatigue. can say to someone it's a bit like having flu. But for many people, actually, the answer is correct, none. And many people have no side effects. But so in effect, the first answer, none, may be correct for most people. But we have to warn people, you may feel low off colour, headache, nausea, fatigue are very common. They don't tend to cause depression or neutropenia. The old hepatitis C treatment would cause depression and neutropenia, but not the modern treatment. Next, please. So deciding which one to use, if we look at glusaprevir, prasvitavir, Mavorite, keep going to the next one. 3 tablets with food once a day, 8 weeks of treatment. So drug interactions will certainly, one of the most important ones is containing more than ethanol estradiol with more than 20 micrograms. The similarities, they work for all genotypes. There's a small risk of reactivating hepatitis B. That's why it's important to make sure someone doesn't have current hepatitis B infection. And they're very similar side effects. Sofval is just 1 tablet a day with or without food. It's 12 weeks. It does have some interactions, but most of these interactions can be worked around. We're going to talk about that in the next slide. So just the next slide, please. So there's a quiz, actually. So which of these answers is correct? It's Sofval for 12 weeks, glusaprevir for 8 weeks, or glusaprevir for 12 weeks. So there's only one correct answer. Well, there's one, yeah. So we can just go to the polling now. So it's the there's one. It's A and B is correct. So glusaprevir for 12 weeks wouldn't be used. So it's an only 8-week course. So it's A and B. Next slide, thanks. So one of the other things that is very important to do is to check for drug-drug interactions. And there's an extremely good website, Liverpool, and this has a great interaction checker also for antiviral COVID drugs, HIV drugs, and hepatitis C drugs. So if you open up this website, you can check drug-drug interactions, even for all very complex. So if you have an elderly patient, particularly on many medications, you can type the medicines into the Liverpool website, and this will produce a summary and also details of potential drug-drug interactions. It's important at this point, of course, to discuss the use of supplements and herbal medication. So St. John's wort, for instance, can reduce levels of various hepatitis C drugs. So some just require dose modifications. For instance, statins often have to be reduced, and other drugs are contraindicated. Some that are notorious, like amiodarone. So this is a very good website. Are there any drug-drug interactions relevant for Isabella? Well, potentially, yes. So we'll just go to the next slide. So the the problem is really with oral contraceptives. If they have only, for the mini pill, which only has 20 micrograms of ethanol estradiol, you can actually use either drug. But if it's above 20 micrograms, then you need to use soft valve because that doesn't interact with estrogens. So with Isabella, she could actually use both drugs. If someone's on an oral contraceptive, even if it's a low dose, I often would use soft valve just because there's no concerns about interactions with any estrogens. We can see also that serotype and Ventolin are completely safe. Next slide. That's just the, here we go, yes, some details. This is the summary of what the Liverpool website will produce, and you can download this as a PDF and keep it in the patient's file if you need to. So this is just a summary at the bottom that the low dose estrogen oral contraceptives are acceptable. Next slide. So I might hand over to Tal now about getting specialist approval to treat.
Okay, so doctors who are not experienced in hepatitis C treatment can obtain specialist approval to initiate Hep C therapy by completing the online RICH-C form that you can see there. The turnaround time for specialist approval is generally about 24 hours. The RICH-C is a national study so that medical practitioners in all states or territory can complete the online form and gain specialist approval. By completing this online form, the medical practitioner is given approval for the de-identified data to be collected for the RICH-C study. The APRI score will be automatically calculated when the lab test results are entered. The RICH-C study coordinator may contact the medical practitioner and invite their practice to become a study site, but this is a voluntary process and there's no obligation for them to participate further in the RICH-C study. The next slide. How do you obtain the PBS authority to prescribe DAA? Very simple now, actually. So it can be done through the PRODA portal, request authority. Only 3 questions are asked: the number of weeks of treatment, do you meet the statements? The answer is usually yes. Is there a cirrhosis or no cirrhosis? There's really no need to provide information about genotype anymore. From the 1st of January 2026, patients pay up to $25 for most PBS medicines and $7.70 if you have a concessional card. Since the 1st of January 2016, pharmacists may choose to discount the PBS patient co-payment by up to $1. This is not mandatory and it's the pharmacist's choice whether or not to provide a discount. As for closing the gap when obtaining PBS medicine at the local pharmacy, the eligible patient who would normally pay the full PBS co-payment pay the concessional rate. So those who would normally pay the concessional rate then could receive their PBS medicine without being required to pay that co-payment. And usually the scripts are dispensed monthly. New slide, please. When should you consult with or refer a patient to a specialist? So it could be a patient with advanced fibrosis or cirrhosis, those with extrahepatic manifestations such as cryoglobulinemia, patients with complex comorbidity, patients with co-infection, although I would say that general practitioners are very good with managing HIV and Hep B. Patients who fail their first-line DAAs, patients with acute Hep C, although now you can actually prescribe it as for people with chronic hepatitis C. So some of these patients may already be treated by a GP in a shared care model with the specialist providing advice and support. Next slide, please. So in terms of monitoring, it's pretty minimal for a majority of patients. So apart from the baseline blood test, you only need to check for cure with a qualitative Hep C, PCR, and liver test 4 weeks or 12 weeks after completion of treatment. So we say now that testing of the hepatitis C RNA to check for SVR at any time beyond 4 weeks after treatment completion, that is an SVR4, is adequate, especially when there's concern about subsequent loss to follow-up. So closer monitoring may be required for some patients with cirrhosis, especially those with decompensated cirrhosis, those with poor adherence, or if there's a risk for reinfection. Patients with cirrhosis do require ongoing liver cancer screening during their treatment with 6-monthly liver ultrasound and alpha-fetoprotein.
So just one small point about practical point. Because people need 2 or 3 months of treatment, it's important, because people will only be dispensed 1 month by the pharmacy, that you make sure that the patient is in regular contact with the pharmacy for the repeats, so they don't have any interruption. And also some pharmacists are a bit reluctant to stop the drugs just because they're quite expensive, so you might have to find your pet pharmacy to make sure they'll supply the medications. So yes, Isabella's started on DAA treatment, and she could either use Epclusa or Mavorite. I think it's a good idea to check, at least have a phone consult before the end of the first month to report, and you do that, and she reports slight headache, but nothing else. And she reports she didn't have any missed doses. It's important at that time just to remind her about picking up the repeat. Now, fortunately, these drugs are quite forgiving, but I might hand over to Tao again to discuss the treatment guidelines for missed doses.
Okay, so we know that adherence to DAA therapy is really important and should be actively supported to increase the likelihood of cure. But obviously, some patients may have various reasons for not being able to comply with treatment 100% of the time. So just let's have a look at how we would manage non-adherence with the treatment. So for those with dose interruption of up to 7 days, you can resume their therapy and complete the original prescribed course. But for those who have interruption of greater than 7 days, that occurred within the first 4 weeks of treatment, start again, prescribe a whole new complete course of DAA therapy. For those who have gone beyond the week 4 of treatment, test their Hep C RNA, and if it's negative, repeat testing at week 12 after treatment, discontinuation to test for SVR. If they're positive, then assume that the patient is a non-responder to first-line DAA and retreat with Vocepi. And you can still actually get very good response rate to Vocepi, greater than 90% actually. Okay. I think we're running out of time, so we might just continue with the presentation. So in terms of confirming cure, which we define as an SVR12, which is an undetectable Hep C RNA 12-week post-treatment completion, or an SVR4, which is an undetectable Hep C RNA 4 weeks post-treatment completion. There's really a high correlation between the SVR4 and SVR12. I must say I do a lot of SVR4 testing. Hep C antibody tests will remain positive after cure, so you shouldn't repeat this. If you would do further screening in the future, it should be with a qualitative Hep C PCR. Advise the patient that virological cure does not protect against reinfection. However, if they are reinfected, reassess them and offer them retreatment. Treatment failure is rare, but it is defined as an detectable Hep C RNA 12 weeks post-treatment completion. Next slide, please. So what's the follow-up for people once they've been cured their hepatitis C This really depends on their pre-treatment level of fibrosis. So if a patient had no cirrhosis and they had normal LFTs post-treatment, they're cured. There's no follow-up that's required specifically for the hepatitis C. However, if they do have ongoing risk factors for reinfection with hepatitis C, then offer them an annual screen, or when liver tests become abnormal again. For those patients who are cured but still have persistent abnormal liver tests, look for other causes of liver disease and refer. Be aware that the most common cause is going to be metabolic syndrome or associated with fatty liver or alcohol. So Isabella actually had normal liver tests and an SVR12. She doesn't require any more follow-up. Next slide, please. So for patients who had advanced fibrosis, which is an F3 or cirrhosis, F4, then they do require regular follow-up. It's recommended at least twice a year to monitor liver disease and tied in with the liver cancer screening. So they should be screened for liver cancer. Some people should be screened for varices and osteoporosis. It's always important that review to monitor progression of liver disease, looking for signs of complications such as development of ascites, peripheral edema, hepatic encephalopathy, check to see the risk of GI bleeding, monitor the MEL score and contact a specialist if it's rising. It's recommended that a referral for liver transplant be considered for people whose MEL score 11 to 18. And this indicates that there's advancing liver disease and liver transplant evaluation is needed. This process takes a while, so we don't wait until they really absolutely need a transplant before doing this. So around 10 to 12, I start talking to patients about this. You also need to prepare them about the liver transplant referral and review as well. Next slide. So in terms of maintaining liver wellness after Hep C, it's important to advise them how to do this. So for people who inject drugs, for those with high risk sexual exposure, particularly men who have sex with men who are HIV positive, they have a high risk of reinfection. So discuss strategy for risk reduction. So using clean needles, syringes, referral for opioid treatment program for those with opioid use disorder, provide safe injecting and safe sex education, offer an annual hepatitis C RNA test. For those with reinfection, retreat. They have a good chance of cure if they are non-cirrhotic. Provide advice on safe alcohol use. So our guidelines recommend no more than 10 standard drinks per week for a man or woman. Recommendation would be less if you've got other risk factors for liver disease, such as, for example, metabolic associated fatty liver disease. For people with cirrhosis, I recommend abstinence. It's important to manage metabolic risk factors aggressively, as fatty liver disease can itself be associated with unfavorable liver-related outcomes. For people who have hepatitis C genotype 3, their particular risk of having fatty liver disease associated with their viral infection. So offer counselling on lifestyle modification, and ensure those with diabetes to have good glycemic control. Next slide, please.
I'm just going to quickly summarise treatment, diagnosis and treatment, the importance of the hepatitis antibody and then the RNA test, the pre-treatment assessment, particularly important to determine likelihood of cirrhosis, prescribing medication which may require specialist support, and then it's very straightforward to prescribe these drugs on the PBS, and then follow up, checking the SVR at 4 to 12 weeks. And with the high likelihood that people will be cured, I think it's a wonderful thing to support someone through treatment and to see them cured of hepatitis C. And I think it's a great thing that GPs are wanting to be involved in this process because it's a very rewarding experience. Next slide, please. I might pass over to Donna now to talk about this conference.
My name is Donna and I'm a project officer at ASHM. I'm pleased to announce that the 16th Australasian Viral Hepatitis Conference is coming up from the 12th to the 14th of August in Perth. This year's theme is Every Voice, Everywhere, Turning Ambition and Experience into Action. For more information, please visit hepatitis.org.au. Thank you. I'll pass back to David for the Q&A session now.
So, do we have any questions that have come through?
Yeah, we do. So in the Q&A box, would you like to pick some questions?
Actually, do you mind? I can't quite see it on my screen.
Okay. Or I can read out some of the one I can see. Can you use HCV medication in pregnancy?
Well, they're Class B drugs, so it's not recommended to use them in pregnancy or breastfeeding, but it's ongoing research just to determine the safety in pregnancy, but it's not recommended. Really, any person who's contemplating having a pregnancy should have their treatment done over and done with prior to conceiving, because there's a 5% chance of transmitting from mother to child during pregnancy. So we really want to cure people before they become pregnant.
Thank you. Is Hep B or Hep C more likely to cause cirrhosis HCC or HCC?
Probably
Both can
hepatitis
cause cirrhosis, obviously. Cirrhosis is the biggest risk factor for development of liver cancer. So both viruses are associated with that. But what's important is that hepatitis B can cause liver cancer without having cirrhosis, because it is in itself an oncogenic virus, which is why there are certain populations who are at high risk that we screen much earlier. For example, Asian men at the age of 40, from the age of 40, Asian women from the age of 50, First Nation population from the age of 50, people from sub-Saharan desert area, Africa from the age of 20. Yeah.
Thank you. Should we check SVR at both 4 and 12 weeks post-treatment?
I think you can just do at least week 4 onwards. You don't need to recheck it once you confirm cure, unless they have a risk factor for reinfection.
Thank you. I think we have time for one more question. Sorry, if you don't mind to have a look and see which one you would like to answer. Sorry, David and Tao, would you?
Yeah, just,
okay. So I think there's a question about when we should check the LFT RNA after starting treatment. So if they're non-cirrhotic, I don't actually check until after they get 4 weeks after they finish treatment, at the time when I'm looking to confirm cure. The only time I would check liver tests would be someone who's got more advanced cirrhosis. So for yourself, you wouldn't need to actually until you finish treatment. Then 4 weeks later or 12 weeks after you finish treatment, you want to confirm cure with a negative RNA, and at the same time you check to see if the liver test is normalised. If it hasn't normalised, then further investigation may be needed to find the cause for that abnormal liver test.
Thank you. We can probably do one more, and then we'll close off the session.
Yeah, okay. So the final question is, does it mean that we will know treatment failure or cure only after SVR4? Yes. So to confirm cure is checking the RNA 4 weeks or later after finishing treatment. I mean, I work in drug health, So we have a lot of patients moving in and out of our service. So as 4 weeks after they finish treatment, I'll be trying to confirm that they're cured. Yeah. If you've got more stable patients, you can elect to do it 12 weeks after they finish treatment.
Thank you. And any last words that you would like to give to attendees?
Probably just that it's so important to provide long-term good care to people following treatment, because many people have advanced liver disease, and it's very important we screen for HCC and try and optimize their liver health long term.
And Tao?
I think that don't be afraid to treat hepatitis C. It's very easy now because the majority of patients are actually non-cirrhotic and only have mild liver disease. We have treated the majority of people who are more complex in the first wave, okay? And it's actually, you just need to dip your toe in and you'll find that it's fairly straightforward.
Thank you both. I'd like to extend my thanks to Tao and David for presenting, and also everyone who joined us online. We do hope you enjoy the rest of the session and you also enjoy the rest of your evening. That brings us to the end of the session. Thank you and good night, everyone.
Good night.